This video presentation is about shoulder pain, how to make the diagnosis. I am Mary Lloyd, Ireland, with the Department of Orthopaedic Surgery and Sports Medicine at the University of Kentucky, and it is with pleasure that I show you these slides, many of which are cases that I've taken care of over the years in my orthopedic practice. The objectives are to develop concepts of correlation of anatomy, injury mechanism, physical exam, and imaging to make the correct diagnosis. We will show case-based examples of shoulder disorders, and I'm going to emphasize the importance of making the correct primary diagnosis that will improve patient outcomes and management of shoulder pain patients. When we think about the differential diagnosis of shoulder problems, you have to think, what joint is it, what space is it, or is it referred pain? There are three joints about the shoulder: the glenohumeral, the sternoclavicular, and the acromioclavicular. Oftentimes the mechanism of injury can be one single event, such as a dislocation, an acromioclavicular separation. We also have spaces: the subacromial, the scapulothoracic spaces. The subacromial space is between the rotator cuff below and the acromion clavicle CA ligament above. There's a bursa sac on top of the subacromial, on top of the rotator cuff in the subacromial space. And problems here are oftentimes repetitive, as in a subacromial bursitis, more of a compressive type problem. Another diagnosis, subacromial bursitis. Others refer this as impingement syndrome. However, that doesn't describe the specific entity of what structure is involved and what the problem is. Is it inflammation? Is it tear, partial tear? The scapulothoracic articulation in the back can also have some bursal irritation, some popping. Always look for, when you examine a patient, the scapulothoracic movement, the synchrony of it. Is it symmetrical? There can be issues that start at the neck and involve the scapulothoracic articulation. Oftentimes with shoulder problems, the shoulder problem starts first. Then there is scapulothoracic winging or a sick scapula or an asymmetry of the position of the scapula. So never forget the scapula and examine the scapula in addition to the shoulder. Referred pain. Typically this is repetitive, no specific event. There can be referred pain to the shoulder from the neck, a cervical disc problem, from the scapula. From the lungs, you can have an apical tumor in the lungs that will give shoulder pain. You can also have rib problems, such as a stress fracture of the rib or a cystic problem with the rib. I've seen a couple of aneurysmal bone cysts that refer pain to the shoulder. So if it doesn't seem typical, think about a referred pain from the neck, lung, ribs to the shoulder. Functional anatomy, the joints, the glenohumeral joint, or what we would term the shoulder joint, the acromioclavicular joint, the AC joint, the sternoclavicular joint, and then the two articulations or spaces, scapulothoracic and subacromial space. In striving to make the primary diagnosis, you've got to name the involved structure. We can go with certain odds. In age groups less than age 30, most likely the diagnosis is going to be initially instability as a primary diagnosis. They may end up having rotator cuff weakness, but the primary diagnosis or the underlying problem is most likely instability or something to do with the capsule or the labrum, such as a slap tear. 50% of slap tears have instability. In the older individuals, older than age 40, think about the rotator cuff as being the primary problem, not instability. We get a little stiff as we get older, so it's not an instability issue. More of a rotator cuff dysfunction, typically a compressive rotator cuff problem from above, a subacromial bursitis, compression problem, or a partial tear or tear. And then think about the diagnosis also. Is it inflamed? Is it torn completely or partially? Is it sprained? Or is it instability? And then think about the direction of the instability. Is it anterior, posterior, multi-directional? Laxity becomes instability when they visit the doctor. The muscle groups which stabilize the scapula are the extrinsic shoulder muscles, most of which insert directly into the scapula. The latissimus dorsi and pectoralis major have indirect action on the scapula through their attachments to the humerus. The scapular stabilizers can be divided into elevators and depressors, upward and downward rotators, and protractors or abductors, and retractors or adductors. It is important to understand these muscles, and the way that they stabilize the scapula is oftentimes you can have scapular dyskinesis, which must be addressed before a shoulder problem will improve. Oftentimes, the scapular winging in athletes is secondary to a shoulder problem. Elevators and depressors of the scapula are shown. The chief elevators are the middle trapezius, levator scapula, and the rhomboids major and minor. The chief depressors are the latissimus dorsi, pectoralis major, lower part, and there are also accessory depressors, as seen on the front view on the right side of the screen: serratus anterior, the lower part, pectoralis minor, subclavius, and the lower part of the trapezius. As shown centrally in this primal diagram, elevation and depression of the scapula. So the elevators as shown in the diagram on the left, and the depressors as shown in the diagram on the right. These muscles must be acting in synchrony to balance the scapula and create the firm, stable base that is needed for sport. The downward rotators of the scapula. Chief is the middle trapezius and the serratus anterior. The chief downward rotators, shown on the right from the back: levator scapula, rhomboids major and minor, pectoralis minor. There are also accessory downward rotators: pectoralis major, lower part, and the latissimus dorsi. We do see neurologic stretch injuries. The long thoracic nerve palsy would create serratus anterior involvement and scapular winging. The protractors and the retractors are shown. Protraction of the shoulder is actually abduction. The chief protractors are the serratus anterior, pectoralis minor. Accessory protractor is the pectoralis major. The retractors are trapezius, rhomboid, major and minor. Accessory retractor is the latissimus dorsi. Oftentimes we'll see the scapula go into a protracted position with a thrower, which is secondary to a rotator cuff problem or a labral problem usually. So check the scapula for symmetry and think about relative weakness of the retractors causing the scapula to go into protraction and internal rotation, moving away from the spine. Also the abduction and adduction of the shoulder involving these scapular stabilizers, as well as the latissimus, deltoid, pectoralis major. And flexion and extension of the shoulder. This moving diagram makes us appreciate the importance of the synchrony and the agonist-antagonist function of the muscles that must work in balance, or injury will occur, particularly in a repetitive overhead athlete, whether it be throwing, landing on the upper extremity, or swimming. Clinically, a good way to check for scapular winging is to have the patient do a push-up on the wall. You can see as depicted here, the left scapula is shown winging, indicating weakness of the serratus anterior, involvement of the long thoracic nerve. The reported range of segmental innervation is C5 through 8. Usually it's C6, so this would be a neurologic problem, and there is significant amount of wasting and asymmetry when you examine these. Again, in athletes, oftentimes the winging is a bit more subtle, with the muscles appearing to be normal without atrophy, but there's a change in position of the scapula, particularly the scapula goes up into forward flexion, protracted position. And you can also use the seated dip, half Nelson, and vary wall push-ups. We should have patients reproduce their symptoms. If they need a golf club to do that, if they need a prop, whatever they need, a bat, have the patient show you what's popping or what their symptoms are, particularly if it is a repetitive overuse problem. If the scapula is unstable, shoulder problems will result. So this is a which comes first, the chicken or the egg. Oftentimes, in my experience, the shoulder problem comes first, and then the scapula compensates for that problem. The glenoid is connected is in the same bone as the scapula. So if you have an instability problem, there can be scapular movements to allow for better stability with the glenoid staying underneath the proximal humerus. It has been said that an unstable scapula is similar to firing a cannon out of a canoe. It's not going to be very effective, and if you're a thrower or a tennis athlete, if you have abnormal scapular mechanics, your shoulder will end up having some problems such as a labral tear, rotator cuff tear, or problems with instability. So remember the scapula. There can be tightness anterior. Patient can be in a forward head, such as looking at all the devices we're using these days, or in a computer situation where you're in that forward head, increased thoracic kyphotic position. This can lead to over-direct developed pectoralis if they're doing a lot of weight lifting, tight anterior capsule. When we assess the scapula, you can do a command of have your elbows put into your back pockets and try to touch the medial borders of the scapula. Doing shrugs is also important. Working on clockwise and counterclockwise movements of the scapula. Have the patients visualize that their scapula is like a clock face and have them rotate it 10 times clockwise and then counterclockwise. Again, engaging all the scapular musculature in the back, which need to be balanced, of the serratus, trapezius, and rhomboids. The individual had had a left shoulder labral repair. He comes in with pain in his left shoulder about 8 years after his surgery, stating that it felt like it was before. We asked him to demonstrate his complaints. He's a golfer, a right-handed golfer, so you can see how his scapula is winging. And this was actually a primary problem with him. His shoulder was really okay and didn't have any evidence of a re-tear of his labrum. But you can see these tests that we do where we have them do a palm press in front. See how protracted forward and elevated the scapula is compared to the opposite side. You can have them put their hands on their waist and have them push back towards you. Not as obvious an asymmetry. Maybe the scapula is up a little bit. And then if you have him do his swing, he will very well demonstrate the scapular winging that he's experiencing. So working on his scapula allows him to have full recovery and return to his sport. If we just looked at his shoulder, he would not have improvement. So remember to examine the scapula in all cases. That's usually what I start with before I start with the shoulder. Similar to the anterior knee problem, we don't do knee exercises initially. We start up at the hip. Well, if you have a very inflamed, irritated shoulder, if you start with the shoulder and don't address scapular mechanics, they're going to get worse. So think about addressing the scapula before really vigorously working on strengthening of the shoulder musculature. Also in a pitcher, you have to think about contralateral problems with their hip, of hip weakness, core weakness, hip abduction, external rotation weakness. So here are cannon and our canoe. So if you don't have a stable base, it's like firing a cannon out of a canoe. Your shoulder is going to break down and get worse if the canoe isn't stabilized, or put the cannon on the ground. Also, another analogy is like trying to crack a whip if your feet are not on the ground. So you have to have a stable base from which to start overhead activities. Is pain referred? Is it coming from their neck, scapula, lungs, ribs? Is it a tumor? Do they have night pain? So if it's a pain that isn't quite classic, make sure that you do a thorough exam of those body parts. This is a neurologic problem. He had a suprascapular nerve stretch, came in with shoulder pain. And again, look at the asymmetry. It's his right side. You can see where there is a concavity or a hollow in the scapula. He was doing 20-pound dumbbell presses, flies, and developed a suprascapular nerve stretch injury. His shoulder does hurt because his supraspinatus is weak, but it's from a neurologic stretch injury, and this is a young college student who shouldn't have that amount of atrophy. So if you have him do a dip, he has difficulty doing this, and you can see the significant difference in the size of the scapular musculature in the scapula laterally, which is his supraspinatus and his infraspinatus. When we have him do a push-up against the wall, again, more the asymmetry of the left where the normal muscle is bulging out in the scapula and the right. Testing him neurologically from the front, doesn't look very happy, but he is neurologically intact, other than his C5 suprascapular nerve that was confirmed by an EMG, nerve conduction velocity, normal spine films, his cervical spine, as well as shoulder films. He improved with relative rest and avoiding a stretch type mechanism of heavy overhead weightlifting activities. We think about muscle testing. This is a very detailed chart, but I think it's a good one to understand and know that you can refer to this. This is from Rockwood and Matson's The Shoulder. Think about the muscle, the innervation, the myotomes, and the technique for testing. We can't test a muscle in isolation. So, for example, if you're trying to test the rotator cuff musculature, the suprascapular nerve, which is C5, sometimes C6, the description is against resistance of external rotation. When we put the arm in a 90-degree abducted position with the palms flat, paralleling the floor, we're testing more deltoid. If we put their thumbs down in a pronated hand position, forearm position, then that does isolate somewhat the supraspinatus, but no muscle acts in isolation. So if they're very weak there, that gives you some information about the supraspinatus. In the thumb up or supinated position, more isolates the infraspinatus. So understand the innervation of the muscles, the trapezius and sternocleidomastoid, the spinal accessory, serratus anterior, the long thoracic nerve, deltoid, the axillary nerve, subscapularis, the subscapular nerve, supraspinatus, infraspinatus, the suprascapular nerve. Differential diagnosis of the shoulder. Again, the emphasis of making the primary diagnosis. There can be secondary diagnoses that occur. Think about the involved joint, diagnosis, pathomechanics, and the most common sports. Glenohumeral joint, we think about instability. If it's bacrotraumatic, typically it's a unidirectional anterior direction. Labral tear as an overuse, throwing, weightlifting of a slap tear. You can think about the labrum as having different quadrants. That slap is the superior, anterior, and posterior quadrants, more symptomatic than the posterior superior. Instability anteriorly is the anterior, superior, and inferior. The classic Bankart lesion is the anterior inferior glenoid with a fracture. Subacromial space. In the older population or weightlifters, we think about this being a compression problem, where if the rotator cuff is not functioning, the space gets to be less, particularly in overhead lifting or throwing. So you have a compression problem from the acromion, clavicle, CA ligament above. In younger individuals, the problem is more of instability of the shoulder, and then you end up with a rotator cuff problem because it's a distraction problem, such as in throwing baseball, overhead tennis. Acromioclavicular problems, think about arthritis in a weightlifter, the weightlifter's shoulder of the AC joint. These individuals also have glenohumeral problems, mainly because of their sport of weightlifting and using the shoulder in a non-meant-for way. Neurologically, looking at the scapulothoracic articulation, think about the serratus anterior, long thoracic nerve involvement. We see this sometime in baseball and archery. Also, there can be scapulothoracic problems from multi-directional laxity or instability, underlying lack of strength in swimmers and tennis athletes. This is a gross dissection of a right shoulder. This shows the rotator cuff. We now have the scissors under the supraspinatus as it inserts, and the biceps tendon runs in a groove. A lot of action in the bicipital groove, biceps glenoid labrum anchor, and the supraspinatus. Clinically, it can be very difficult to tell which one of these is the primary diagnosis, so we make that diagnosis based on the history and physical of the patient. The primary diagnosis may change on follow-up visits, but make a primary diagnosis. Up above you can see the fixed bony arch of the subacromial arch and the CA ligament. The rotator cuff is the sit muscle, supraspinatus, infraspinatus, and teres minor. These are the external rotators. There is a balancer or an internal rotator called the subscapularis, and that should not be forgotten. You can palpate the muscles doing manual muscle testing. Again, in the thumb down position, more isolates the supraspinatus, thumb up the infraspinatus at 90 degrees based on EMG testing. You can also palpate the most typical rotator cuff tears of the supraspinatus at its insertion on the greater tuberosity. If you rotate the shoulder, you can oftentimes feel crepitus and sometimes palpate a defect in the supraspinatus at its insertion. So internal rotators, external rotators. The internal rotators, the fourth part of the rotator cuff subscapularis is shown in the middle. Also the pectoralis major, anterior deltoid are internal rotators, and the latissimus dorsi and teres major. The external rotators are the sit external rotators, supraspinatus, infraspinatus, and teres minor. Rotator cuff testing. Empty can position, weakness in external rotation. So in the middle is your test for the supraspinatus, and on the right is your test for the infraspinatus. Again, if you really ask patients to fire muscles, it's not going to isolate one muscle. The deltoid kicks in. The test on the left is more palpating, rotating the shoulder. And if we internal rotate the shoulder, the space of the subacromial space gets to be less, so that can create pain. And if you have people with rotator cuff inflammation or even a tear, sometimes they will change the position of their hand, forearm, when they try to abduct on your command. And this is to try to reduce that compression in the space to avoid pain. The rotator cuff can be inflamed, it can be torn partially, completely. We can tell which parts of the rotator cuff are torn. Typically it's the supraspinatus. In grading the size of tears, a large and massive tear involves both the supraspinatus and the infraspinatus. The rotator cuff is like a sandwich in between two bony structures. The acromion clavicle CA ligament up top isn't moving, that's the roof. The proximal humerus is going to move proximal if the rotator cuff is torn and the deltoid takes over unopposed, so the humeral head becomes high riding. So you can think about this rotator cuff sandwich, if you will, as being an articular side on the bottom and a bursal side on the top. So is this more of a bursal-sided compressive problem? Is it more of an articular-sided partial tear of the rotator cuff, as we see in throwers, or is it a complete rotator cuff tear in an older individual? Complete tears can be compensated for. If the tear is well balanced, it can be like a suspension bridge, where the free side of the tear is the cable, and the attachments of the tear are the support on either end. So if you have a balanced rotator cuff tear, sometimes patients can have full range of motion. When we do rotator cuff repairs, we mobilize the cuff. These are traction sutures in the cuff, so we pull the cuff back down to the greater tuberosity. This individual is relatively young. You can see the great vascularity above in the bursal side, so you can see that bursal tissue on top of the wider taut tissue of the supraspinatus and the infraspinatus. So we mobilize this, and it's much like putting a window shade back down to a sill. We've made great advances in arthroscopic work on rotator cuff repairs. Most of them can be done through the scope, but at least now we don't have to detach deltoids and take muscles off of their origin. If we do a mini open, it's a deltoid split. It's very important to mobilize the cuff, make sure there is no further compression on the rotator cuff from above. And this also will allow you to do what work you need to do through the scope. So subacromial decompression, more to remove the bursa. The ligament is less rarely resected, only resected if it is frayed and definitely causing impingement of the supraspinatus. This is a 75-year-old with a massive rotator cuff tear. You can see on these plain x-rays in the outlet view on the left and his abducted attempted striker view that the proximal humerus is really articulating with the acromion. It is high riding because of the unopposed deltoid causing the humeral head to go proximal. If the rotator cuff had been working recently, there would be some depression of the humeral head and articulation with the glenohumeral joint, as opposed to now a new joint of the humeral head acromion. See some narrowing of the AC joint as well. So this is a classic example of x-rays of a proximal riding humeral head and a massive rotator cuff tear. When imaging with an MRI scan these tears, one must go far enough medial in the views to assess the amount of atrophy of the muscle, because this is very important if we are to know if we can repair the rotator cuff at the time of surgery. It would be very unlikely that this patient would be able to have a successful rotator cuff repair. Here is his MRI scan. The white is the fluid that leaks out of his joint. He has AC arthritis, and essentially now the humerus is articulating with the acromion, with the cuff retracted significantly proximal to the level of the glenoid. Full thickness supraspinatus tear. Images are getting better and better. Don't need an intra-articular gadolinium study for rotator cuff assessment, but you do need to go far enough toward the muscle of the supraspinatus and the infraspinatus on the axial and en face cuts so that you can see the muscle. So I'll tell patients that the rotator cuff tears are like a window shade that is no longer connected down toward the sill. There will be increasing size of the rotator cuff tear over the course of years. It starts small, but with the origin still attached, there will be further retraction of the tear, and we do see rotator cuff tears that are massive, that are not repairable. So I think this is a good way to explain to patients what the problem is with waiting, and then in principle what you're trying to do is to put that shade back down to the windowsill. MRI scans are good ways to assess the size of the tear, the chronicity, and there are people who certainly don't come in soon enough for evaluation of their shoulder pain, and by the time we get them they have a massive tear that is sometimes not repairable. There are many clinical tests named after someone. Instead of describing that name, I think it's a good idea to think of the motion of the joint, the forces you apply, and you can use this as a descriptor in your dictation or your template. So think of the motion of the joint and the forces that you apply. If it's a labral problem, we want to apply axial load like a McMurray's of the knee for a meniscus tear. So if it is a rotator cuff problem, you have to think of it as a compression or impinging problem. So anything that you do to lessen the subacromial space will cause problem. Or is it an instability problem? Distraction of the capsule, subluxing the humeral head. Do the most painful part of the test last. I do start off looking at the scapula, do a seated exam, have the patient actively move their shoulder around, and that'll give you an idea of what you'll be able to do with their exam. If they're forward flexed in a kyphotic position, oftentimes everything hurts, including touching their neck, their scapula, or their shoulder. Others have a rotator cuff tear and may have full motion, but you really hurt them if you do manual muscle testing in empty can position and tell them to resist, because they usually will, and they'll have a significant amount of pain. After examining the scapula, then do a seated exam. I think this is an excellent way to do exam for stability and also passive motion. You can tell whether there's a defect in the rotator cuff at its insertion, pain over the biceps and the bicipital groove, rotating the shoulder with the arm at the side and then bringing it up to 90 degrees. You can't do all of the tests. Pick the best few tests in your hands and do them on the patients. After my seated exam, I'll do a supine exam, and then on occasion we'll do a prone exam to palpate the scapula, stabilize the scapula, and posteriorly luxate the humeral head, putting the arm toward the table and pushing back on the humeral head. You can stabilize the scapula and then go into an external rotated backward flex position, and if they have anterior instability, they won't like that. There are a lot of named tests. Sometimes the people for whom the test is named don't know what that test is. A prime example of a lot of named tests are for biceps tendon disorders. If we have this many named tests for it, it's better to stick with just a few and talk about what movement you are doing to reproduce pain. Oftentimes, if you listen to patients, they'll tell you what movements bother you, and you can make a diagnosis before laying your hands on them. So for biceps tendon proximal labral problem, we know from arthroscopies that if we externally rotate the arm, this is a peel back, and the labrum, if it's torn, peels back, oftentimes with pain clinically into the biceps. Just like in McMurray's maneuver, axially loading and rotation will create pain, but do the most painful part of the exam last, and you can kind of bet on which part this is going to be based on their age and their sport. So these names for proximal tendon dysfunction of the long head, these are only 6 to start off with. We can include these for a complete exam, but rarely is a biceps tendon problem isolated. Prior to arthroscopy and our better understanding of partial tears, slap tears, rotator cuff tear, problems with the capsule and instability, by looking with a scope and understanding the biomechanics in the lab, we made the diagnosis of an isolated biceps tendon problem all the time. We're now better at diagnosing based on our physical exam and our MR imaging. We also have to think about the subscapularis and a partial tear of the subscap, particularly in association with medial instability of the biceps, as we see on MRI scans, which we would see on MRI scans. So I'll talk about all these tests. We can also describe what we're doing when we're doing these tests, but basically we're rotating and wrapping up the biceps, creating pain in the bicipital groove. The position of the Abbott and Saunders test, little axial load going into external rotation and then internal rotation. You're palpating the biceps, and this creates pain. The anquins, more of a supination, not quite as abducted as the previous test, and Matson's test with pain directly over the bicipital groove and the biceps proximally. The Seeds test, as shown here, the palm is up, forearm supinated. You ask the patient to flex their shoulder against the resistance of your hand with the elbow extended, and this creates pain in the proximal biceps in the groove that you're palpating. So if this creates pain, then it's a positive test. Again, if you think about it, you're wrapping up the biceps either in the extremes of internal or external rotation. This is a modified peel back that we have developed and we understand from arthroscopic pictures. Yersin's, another named test. This is with the arm flexed. Patient is asked to forcefully supinate against resistance. Pain in the anterior aspect of the shoulder and the bicipital groove is a positive result. So again, you're doing it more in a flexed position against forced supination, which the biceps does, the pain in the proximal biceps area. Ludington's test. Hands are behind the head. Patient is asked to flex the biceps. The examiner's finger is in the bicipital groove. Pain occurs when you're palpating the biceps in the groove. And you ask them to do as in a sit-up maneuver. There can be differences in concept of the biceps tendon looking at this with this maneuver. If there is an asymmetry, you must think about a biceps rupture, that Popeye deformity that we would see in a complete biceps tendon rupture. Oftentimes it's spontaneous. The biceps is a pain generator. The biceps tendon attaches to the labrum. This is the biceps glenoid labrum anchor. And oftentimes with a tear of the labrum superiorly, the pain is generated down into the biceps. The labrum functions as a stabilizer, a bumper for the attachment of the biceps, and a shock absorber. So oftentimes in making a diagnosis, if you look at the proximity of the biceps and the glenoid and its anatomy, A slap tear involves the biceps. Therefore, there will be pain that is generated down into the bicipital groove and the entire anterior aspect of the shoulder. If the labrum is torn, as in a slap lesion, these tears can propagate into the biceps itself. And the shoulder in 50% of the time will be unstable because of this detachment of the labrum superiorly. The classic Bankart lesion is the anterior inferior glenoid labrum that is torn, oftentimes a little piece of bone of the glenoid, which can still be attached with the capsule anterior inferiorly. Sometimes it can become a loose body. So the inferior glenohumeral ligament, or the ACL of the shoulder, then becomes unstable because it's no longer connected to the labrum, which is connected to the glenoid. Another analogy that we can think about is the humeral head being like a big golf ball in a shallow tee. That Bankart lesion anteriorly, if you knock off or fracture that glenoid, you don't have the normal concavity of the glenoid, and it's almost like breaking off the front part of a tee. If you try to use that tee to stabilize your ball, the ball will fall off. So hence the instability that occurs. And when we do stabilization surgery, we recreate that bumper effect by putting the labrum and the capsule back up to the tee, creating that normal concavity and stability for the golf ball. Another analogy that I think is very important is the circus seal under the ball. Think of the circus seal as being the scapula, and his little nose is the glenoid. So if the scapula is sick and not in the right position, the glenoid is also not going to be in the right position under the humeral head. So it can be a problem of instability where the humeral head's coming anterior, but also the glenoid isn't functioning normally or isn't in the right position, and then there can be a multi-directional instability of the shoulder. And addressing the labrum is important, but if it is more of a multi-directional voluntary instability, if we can get the scapula well, then the shoulder will not require surgical intervention, particularly if it's more of a capsular looseness that is natural. Another analogy that I think is good for a slap tear is the contact lens on the eyeball. So if there is a little rent or tear in the contact lens, then it's not going to have that normal communication with the eyeball, and there will be pain, bubbles, things won't work very well. So what we try to establish when we do arthroscopic surgery of labral reattachments, as in a slap repair in the normal tissue, to put it back onto the glenoid and reestablishing that very fine, balanced relationship of the contact lens on the eyeball, or the labral communication to the eyeball itself. Contact lens to eyeball, labrum to the glenoid, to the humeral head. When we look at tests about the labrum, this study from 2003 in the Arthroscopy Journal is a prospective study, 61 shoulders and 62 patients. These are the tests that were used for labral tears. We've talked about a lot of these tests specifically for the biceps. Again, the biceps is the attachment to the biceps glenoid labrum anchor. And if you have a problem with the biceps, oftentimes it starts with a slap tear or a tear in the labrum itself that propagates into or transfers pain down into the biceps tendon, which is a pain generator. So in this study, only the O'Brien and Jobe relocation test were statistically correlated with a labrum tear, including a slap tear. The other 5 tests were found not useful for labral tears, And none of the tests or combinations statistically valid for a slap lesion only, meaning that a lot of these, particularly baseball athletes, have combined problems of a slap tear, perhaps instability, microinstability, anterior instability, as well as rotator cuff problems. So this is the O'Brien's test. The right position that creates pain is shown on the right side in the thumb down or empty can position. The examiner asks the patient to push up against them with the hands touching. On the left shows the position where pain is relieved. This is a positive test if they have pain in the empty can position, and then it improves in the palm up position. You can also have pain in the AC joint, but if it's pain that is deep, this is more of a slap, consistent with a slap tear. And this is Dr. O'Brien's description from New York of the test. And I find this a very useful test, as supported by the previous study. So this is a video of this test. He is in the empty can position. I'm asking him to resist me. If they hurt in their proximal biceps and then it improves in the palm up position, that indicates a slap tear, irritation of the biceps. If the pain is more superficial, that would indicate a primary acromioclavicular problem. This is the peel back sign. This is a arthroscopy of a right shoulder in the lateral decubitus position. The humeral head is on the top. The structure that's the white structure in the front is the biceps tendon. There's a subscap down below. And this person has a Buford complex in a normal variant attachment in the front, but you can see the labrum in the back peels back, and there's a space between the glenoid and the labrum. So this is the normal anatomic variant of the middle glenohumeral ligament and essentially absent anterior superior labrum, but where the labrum starts just toward us from the green cannula is where the slap originates. So we externally rotate, and you can see where that peels back, and then we internally rotate. So that's the position of the O'Brien's test, an internal rotated position, and then it peels back. So clinically what we see is we see instability and pain in both extremes. So here we are in external rotation, and then we go to internal rotation. So clinically there's pain in extremes. You can see the subscap down there in the upper left-hand corner. Normal subscap, normal variant of a Buford complex anterior superior, and a peel back sign associated with a slap tear. So we've learned a lot from looking at arthroscopies, learning what we see in certain sports and correlating that back to mechanism of injury and biomechanics in the lab to understand what's going on, and more importantly, what needs to be fixed and not fixed. So the Buford lesion is an anatomic variant. We don't do anything with that. We fix his labrum, restore normal exam, including the scapular position, the best mechanics possible in his sport, and return him to play. May take up to a year after a slap repair to do that. So external rotation, internal rotation, and think about this as it correlates with what you're doing on your physical exam. So the O'Brien's test causes pain. External rotation also causes pain, as in when they're throwing overhead and maximal cocking. So this is a MRI scan of a left shoulder, someone who has a detached labrum. You can see the gap from the glenoid. This is best seen in the lower left, where the labrum is the triangular structure that is well away from the proximal humerus. A slap lesion in someone who also had instability, normal rotator cuff. Labrum should be attached where the arrow is, and it's well displaced. This patient had improvement with arthroscopic stabilization, but continued to have pain into the biceps. As we've repaired more labral tears, we are looking back at who needs a labral repair, what are the ages of successful repair, and now probably patients in their 40s would better benefit from debridement of the labrum and doing a biceps tendon cutting, a tenotomy, where you let it fly, or a tenodesis, where you park it to other tissue, subcutaneous into the area of the rotator cuff, or sometime into bone, subpectoral into the proximal humerus. The biceps is a pain generator. Sometimes the way to get rid of the pain is to cut the biceps, which you really have to explain to patients why you're doing that. There can be some subsequent weakness of the biceps of elbow flexion and asymmetry if the tenodesis becomes a tenotomy. But in general, the patient's pain is improved. There could be some minor cosmetic differences one side compared to the other. This is a slap tear in a young pitcher. You can see in the upper left-hand slide, we're lifting the labrum. The biceps is the white structure up on the left. This is definitely a peel back, so the labrum is peeled back from the glenoid. To be able to successfully repair this, one must prepare the glenoid, get it down to a bleeding base, and then the blue suture in the middle upper picture shows the labrum is repaired. And if you think about that, a couple of sutures are holding that labrum where it should be. It takes a long time, months, before that's secure enough with the healing back to the glenoid to be able to withstand the significant torque of external rotation and throwing a ball. This young pitcher had primarily a slap tear, kept on throwing, and he ended up with a rotator cuff tear. We're seeing this more and more. He had a partial articular sided tear, which is called a posta lesion. So you can see here where we've got a blue PDS suture coming in the upper right to identify where this tear is, and it was almost all the way through, so we elected to repair this. Didn't take it down. There's some controversy about what to take down. He had pretty good tissue, so we did this repair, putting the anchors in. The lower left is where you can see the sutures coming through. We had 2 anchors. In the middle picture on the lower section is the subacromial space, where you can see these are tied down in the subacromial space, and then the lower right is an example of what the rotator cuff now looks like under the correct tension. So this was a insufficiently functioning rotator cuff that we had to put down to the greater tuberosity, and we did this without taking down the footprint of the rotator cuff, but we did prepare the bed at the greater tuberosity. So this is a great example of a slap tear in a young pitcher who kept on pitching, ends up with a rotator cuff tear and a repair. He was out for 6 months, no throwing for 6 months, did a little tossing, returned to baseball, not pitching at a year. So he was unable to return to his former position as a pitcher at the age of 15. Retired from pitching because of an injury of a slap tear and a rotator cuff tear. We're seeing more and more young pitchers with rotator cuff tears. This should be stopped, and our campaign, the Stop Injuries campaign, should be instituted in baseball. Spread the word. Examining the patient in a seated position is very effective. You can palpate the landmarks, the AC joint, the glenohumeral articulation, inferior luxation, and then anterior posterior rocking the shoulder. So I've got my hand on the proximal humerus and I'm rocking in and out to get a sense of the stability going forward and backward. And now in external rotation, we bring him back in a crank test. If he has a labrum tear, this is our peel back position. So he would be hurting here, but also if he had anterior instability, he wouldn't like it much when you get him back in the externally rotated abducted position. Ask him if that reproduces his pain. Internal rotation can also, if you have a labral tear, such as a slap tear, the extremes of internal or external rotation by clinical exam can reproduce pain. Look for symmetrical motion as far as the rotation is concerned. Then we go to a supine exam. Make sure they're close enough to the side of the table so that you can palpate their humeral head. So into internal rotation in the upper left, and then into external rotation. So if she had anterior instability, she would be apprehensive in this position. And again, you're rockering the humeral head forward in that position. And then on the right is the seated exam. This is almost like a lockment of the shoulder, if you will. I'm holding the acromion, clavicle still, and then rockering back and forth. And even in a big athlete with significant development of their deltoid, you can get underneath and use your index or long finger anteriorly and rock them back and forth. And then if she has anterior instability, as in the lower right, she's not going to be very happy as I'm stabilizing the scapula, and this will cause her to have apprehension if she has anterior instability. Again, a supine exam, external rotation. You want to look for the passive range of motion when you're doing this. Some people grab the humeral shaft and will bring them forward, anterior, or backward. Personally, I like palpating more proximal, but this is our crank test, our instability test. So I bring my long finger deep to the deltoid posteriorly and then put my thumb on the humeral head and basically rocker the humeral head anterior and then posterior, anterior and then posterior, and you ask the patient what reproduces their symptoms. Look for symmetrical internal rotation and external rotation. Pictures typically have loss of internal rotation and greater external rotation. This is a case of a freshman football athlete at one of our college schools. Never had any problems opening game. Came out of the game stating his arm was numb, dead arm complaints. He thought that he fell on his shoulder laterally while being tackled. Clinically, he was unstable, had anterior apprehension. He had an axillary nerve palsy with numbness over the deltoid, but he did have motor was intact. He was not dislocated at the time of his exam. I did not let him go back into the game because of his weakness, because of his deltoid numbness and his instability. We got x-rays. This is a probable Hill-Sachs lesion where there's radiolucency in the greater tuberosity. However, we don't have an axillary lateral view. Here is our axillary lateral view. So regular view that we get is on the left. And do an axillary lateral view in external rotation as well, and you can better see the posterolateral humeral head compression defect called a Hill-Sachs lesion. This is a good view to get to look for on plain films the Hill-Sachs lesion. You can see the indentation on the modified externally rotated view, but not on the regular neutral or even internally rotated view. The coracoid is there on the right-hand side of this x-ray. MRI scans. We did not use intra-articular gadolinium. This is blood that's on the inside of the joint from his dislocation. So acutely, we have our own arthrogram, if you will, because of the blood that's intra-articular. He did have a very significant Hill-Sachs lesion, 25%, and there was labral detachment of the entire anterior aspect of the labrum from the glenoid, indicating an anterior dislocation most likely that's self-reduced. This is pretty common in football. They may not remain out, so it's very important to examine them on the sideline to determine if they should return to play, because a redislocation is very likely if they've just dislocated even for the first or second time. Here's a C of the axial view axillary lateral view, if you will, of the MRI scan. See the biceps anteriorly, and in the back you can appreciate the Hill-Sachs lesion with what looks like a rat bite seen on the T2 image on the left. So this is the Hill-Sachs lesion, estimated to be 20% of the humeral head. And if you look at that wedge of the labrum anteriorly, there is a tear where the blood is between the labrum and the glenoid. Great view of thinking about what happens with an anterior dislocation of the Arthroscopically, first-time dislocator, we scoped him. He had an anterior instability event for the first time, had significant instability clinically, and had avulsed his labrum. Ideal opportunity to do surgery, and the indications are sound. This is in the lateral decubitus position, so we're looking from the scope in the posterior portal. And this is the significant injury that occurred with just one dislocation. So you see the heme in there from the hemarthrosis from the osteochondral fracture of the Hill-Sachs lesion, and also from the avulsion of the labrum anteriorly. The upper two pictures are great examples of his Hill-Sachs lesion. It's not that big a Hill-Sachs lesion, but this is the result of his anterior dislocation. So the lip of his glenoid anteriorly caused this fracture of the posterior lateral humeral head. But the most significant portion here to look at is the bottom two pictures where there's significant articular cartilage injury to the anterior portion of the glenoid. You can see here all this peel back of the articular cartilage in addition to the labrum has been injured. And with newer MR techniques, we're better seeing the articular cartilage, but we didn't appreciate that there would be this amount of articular cartilage damage where it basically just peeled off. And if you think about this being a bumper out in the front for stability, his labrum is very beat up after one dislocation, and then we debrided this cartilage that was loose back to bleeding bone and then did an arthroscopic repair. So the damage done with a single dislocation is often underappreciated by the physical exam, and MRI scans give us a lot more information about what's going on with the labrum and the bone. Posterior instability. Ask the patient what causes them to have clunking of their shoulder. What he's doing now, putting his shoulder into horizontal adduction, arm into horizontal adduction, internal rotation. If he had posterior instability, we would be able to see. The patient can demonstrate it sometime better than we're able to examine. So this could be a habitual posterior instability or a multi-directional instability. So if they're able to reproduce their instability, that is a good way for you to make the diagnosis. Sometimes they can do it better than we can reproduce it when we're examining them clinically. So moving the arm into internal rotation, horizontal adduction, there'll be a clunk, and there can definitely be an asymmetry one side compared to the other. So ask the patient to read. The bone posterior instability test, so you're stabilizing the scapula and basically just pushing the humeral head to the back. And you can see here where I've got a scapula stabilized, and I can push on his posterior capsule and see if there is indeed instability. Going the other way, externally rotated, backward flexion would tell me about anterior instability, and I can stabilize the scapula in this way. So an apprehension test going into external rotation, backward flexion indicates anterior. If we can pop it out the back, or he has pain or a clunk or a pop in the posterior aspect, applying axial load posteriorly, that tells me that there's more of a posterior instability. So this is a great prone test that we should do on all instability. What leads laxity to instability? We see certain athletes, female athletes, swimmers, cheerleaders, gymnasts, tennis athletes who have multi-directional laxity. When they come in and have a clinical complaint, that will become instability. And what our charge is to figure out the chronicity of it. Is it voluntary? Is it asymmetric? And what is the direction of the instability? Is it posterior, anterior, inferior, or multi-directional instability? So this is a vicious cycle pathway that I feel leads to the rotator cuff weakness that we see in swimmers. So it starts off with a physiologic laxity, and if you follow me in this clock face, you get capsular distraction, microtraumatic stretching of the capsule, if you will. Usually not that Bankart lesion or that anterior labral detachment that we see in the football player, but then you get rotator cuff dysfunction, then you get more capsular ligamentous stretching, or a labrum tear, but because they're so loose to start off with in these multi-directional laxities, they stretch the capsule out as opposed to knocking off the labrum or knocking off the bumper in the front. Then you can get a partial rotator cuff tear. Then you can get more subluxation of the humeral head, either voluntarily or with the nature of their repetitive sport. It can go in the front, back, inferior, and then this develops into pathologic instability. So we try to diagnose these problems early, put them on a proper biomechanics of their sport, strengthening, scapular stabilization program. And in advances in arthroscopy, we haven't been as successful with working on the capsule as we have as something is knocked off, such as the labrum with anterior inferior glenohumeral ligament. That's very successful, treated acutely with arthroscopy. So this is a multidirectional instability patient. His scapula are symmetric. They do look a little like they're winging, but scapula isn't his problem. So have them do a push-up on the wall to assess the scapula. And now he's able to reproduce his posterior instability. You can see how his scapula, which connects to the glenoid, follows this. And as we put this skeletal model over it, you can better appreciate what he does. So he posteriorly subluxes voluntarily. So now I've got him supine. I'm inferior subluxing him. And then you can see where, again, I hold the acromion and you can rock him out and then reduce him. I'll ask him to sit up straight and do it again, rock him out, reduce him. So this is a posterior instability. So again, levering, rocking him out and then going back in, rocking him out and then going back in. So this can be, in his case, more of a voluntary posterior instability. And then you can do manual muscle testing of external rotation, internal rotation, have them put their hands on their waist to, again, better look at their strength, but also to look at the scapula. So he does tend to wing, which is symmetrical. This is his non-involved side, his left side. And again, this is a multidirectional posterior laxity on the left and instability on the right because he's having This individual had an open anterior reconstruction that clearly was not successful. You can see her sag sign. You can see her acromion that's sitting up there in the breeze, and her humeral head is dislocated basically at this point. Look at her keloid formation from this anterior stabilization procedure that I did not do. She's actually more symptomatic from the standpoint of instability on the side that was operated on. So now her humeral head is inferiorly subluxed. This is her normal side. So you can see the anterior-inferior instability just with gentle traction on her arm. See the asymmetry there where she's greater inferior luxed on her right than her left. We ask her to move her shoulders around. She's not very happy we're taping her, but one of the things she does is she's in this forward head kyphotic thoracic position, which makes her scapula be in a poor position for stability. So in her case, we started on a rehab program, put her in a figure of 8 splint to keep her shoulders back. And you can see when she goes forward, her humeral head comes out. And then if she does shrug her shoulders together, it's in a much better position, as shown here on the left, forward, and on the right, just asking her to put her scapula together and sit up straight, open up her chest. She is now in a better position. Beware, don't operate on. This is an 18-year-old right-hand dominant discus thrower who threw the discus, felt a pop. She was unable to move her arm. She went to the emergency room. We don't usually see x-rays showing a posterior dislocation, but in her case we did get a posterior dislocation in the ER with a good axillary lateral view. Posterior dislocations are still missed in emergency rooms. Typically, it's a more violent problem than throwing a discus. So this patient had underlying multidirectional instability. Usually a posterior dislocation that is fixed is in an individual who has had an electrocution, has had a seizure, or may not be completely with it, and that's probably why these are missed. This is her axillary lateral view. Great axillary lateral view for an emergency room. You do need to have an AP and a 90-degree different view. So you need an AP in some type of a view lateral to tell if the shoulder is dislocated or reduced. So the arrows are on her glenoid, and you can see here where humeral head is out the back. Always look at the coracoid in the front. That gives you a good landmark of what is anterior, where the coracoid is, or posterior, where the acromion is. So this is her exam under anesthesia. You can see we can move her arm any which way but loose, about all the way around, 360 on that clock face. So you can do this crank test of her proximal humerus, or you can lever her in and out of place as we've been talking about with our physical exam. So get under the deltoid, lever out the back. So she's more unstable posterior, which would be the direction that we're going to particularly look at and fix if we can, either an open way or arthroscopic. So you can see her jumping posteriorly out the back when we're examining her under general anesthesia. So this is her view, her externally rotated view, axillary lateral view, and then this is a posterior dislocation, which we rarely see on the axillary lateral view, but in her case we could see it. This is a striker view that is normal in the bottom, but if you look at the difference, the asymmetry, where you see there's a lot of space between the glenoid and the humeral head, that's a patient who has a posterior dislocation, but you do need some type of a lateral view to document that, and you don't want to miss a posterior dislocation because it's very difficult to reduce them and give them a normal shoulder if it's missed for a long period of time, which sometime it is, unfortunately, still to this day. Shoulder pain algorithm. Our academy has an algorithm of how we work up shoulder pain. I think it's very important to, if you're a general practitioner, physical therapist, athletic trainer, understand the shoulder, understand shoulder exams, and probably consult an orthopedist, sports medicine, primary care physician prior to doing an MRI scan. So the imaging that we do and that has been recommended is plain films. We make the diagnosis by history and physical exam and the plain films. We institute treatment. We re-examine the shoulder, give them time to get better, and then special imaging studies are done not at the initial visit but later on. The exception would be an acute anterior dislocation, or if you thought there was subscapularis involvement with significant weakness about the shoulder and an acute injury, then you could consider doing an MR imaging earlier, or certainly if you have a fracture or some significant bone issue, then a CT scan would be So in the shoulder pain algorithm, the initial imaging that is suggested is a true AP in 0 degrees external rotation, a lateral view in the scapular plane, and an axillary view is again a very good image. Sometimes you have to hold the shoulder if they're dislocated. You as the physician have to hold the shoulder and assist the x-ray tech. Appropriate plane x-rays need to be obtained in acute shoulder injuries, and they need to be 2 different planes, an AP and a lateral view. More sophisticated imaging, such as shoulder MR, ultrasound, or arthrography, are not indicated in an initial evaluation and treatment of a patient with shoulder pain. It's unbelievable how many times we see patients come in with an MRI scan that might be a poor scan and no images. And certain things such as fractures, tumors can be So this is our imaging of a routine AP view shown on the left in A, and then a true AP of the shoulder shown on the right. So you should have the anterior and posterior glenoid rim superimposed on the right. These are the positions for these views. AP view and internal rotation is as shown. This is the striker notch view, which I find very effective in looking for a inferior glenoid exostosis, such as in a Bennett's lesion, a thrower's exostosis. Look for AC arthritis. Look for osteoarthritis, the glenohumeral articulation with spurring in the inferior aspect of the glenoid. The outlet view, in this case, is done supine. You can also do an outlet view standing. And this may give us a little more information about the position of the humeral head and whether it's proximally migrated, such as in a massive cuff tear. If you're doing it in a standing position without the patient supporting their arm, it might be migrated proximally, the humeral head. So you can see this is actually a lateral view that would suffice in an acute situation to know the shoulder is located. This is the upright view, so you need to know what you've ordered and what your routine series is. So this is the upright lateral view. And standardize your views. Get views that you're comfortable with and know the position of the patient. So this is a outlet upright view. Humeral head should be dead center on the glenoid. This is our usual axillary lateral view in neutral palm position, shooting 90 degrees to the shoulder. And this is our modified view, which with a humerus and external rotation can show a Hill-Sachs lesion or a posterolateral humeral head impaction compression fracture. Glenoid as seen, but see the sloping of the posterior aspect of the humeral head in the X-ray in the upper right. Now we'll move to the subscapularis. The subscapularis is the fourth part of our rotator cuff. It is an internal rotator. It has a very wide muscle belly and an insertion onto the lesser tuberosity. So seen from the anterior aspect, you can see the subscap. Posteriorly, the infraspinatus and teres minor, our external rotators, balance the subscap. Subscapularis tears, typically it's the superior half of the subscap that we're appreciating arthroscopically that has tears. There's several different tests that you can do. There's a lift-off test. Arm is back in a half Nelson position. You ask the patient to push against your hand, basically reproducing internal rotation. And this lift-off test is present in about 75% of tears. The Napoleon test is present in about 50% of patients. You press the belly, flex the wrist, and they have weakness and reproduction of pain. And Dr. Burkhart has popularized the bear hug test, which is more sensitive for a subscap rupture, particularly the upper half. Put their hand on the opposite shoulder, elbow forward, and the examiner asked to pull the hand off the shoulder. You can do this bilaterally at the same time, and if there's weakness, reproduction of anterior shoulder pain, this indicates an upper half subscapularis tear. This is a patient, 46-year-old, right-hand dominant male, fell onto his outstretched arm after tripping over his dog, felt a ripping sensation, made him nauseated. Went to the emergency room, plain x-rays were normal. Saw him in the office the next day. He had diffuse tenderness in the anterior aspect of his shoulder, and his weakness was more internal than external rotation. Neurovascular status was intact. This is his clinical exam. One complaint was I was unable to get my wallet out of my back pocket when I was pumping gas. I could pump the gas, but I almost got in trouble when I asked someone else to get my wallet out of my pocket. So as you're watching me examine him here, he's trying. He has significant weakness of internal rotation. He can externally rotate, so I help support his arm. He's in a lot of pain, and he really has no internal rotation. He had a complete subscap tear, so I asked him to reproduce his symptoms, which he couldn't really get his arm to his back pocket, and then he had significant weakness and pain. This is his belly press test. Have him push in toward his belly. That reproduces anterior pain, and he has weakness in this test, so he can't support you going back toward him or doing a belly press. Good external rotation, and he is very weak in internal rotation. So think about what the muscle function is doing, and then accordingly test the patient. In the acute situation, make sure you warn them that it may hurt. If you're testing for what you think they tore, such as the subscapularis, there's going to be significant weakness of internal rotation. So anatomically, this shows the subscapularis and the biceps relationship. Here's the subscapularis as it inserts on the lesser tuberosity, the biceps in its groove. If we see the biceps in a medial position on the MRI scan, we must assume that there has been an injury significant to the subscapularis. Subscapularis tears, coracohumeral ligament in the front also is involved, so the stabilizing structures keeping the biceps in the groove have been torn, hence a biceps instability medially. But that's not the main problem. The main problem is a subscapularis tear. So these are MRI scans, axial views. The best seen is the lower left, where the black seen anteriorly is not in the groove. So that's the biceps tendon, which is medial in location, as opposed to it being in the groove itself. You can see here with the arrow the medial dislocation of the biceps tendon. This doesn't show us the subscapularis very well, but beware that there's probably a subscapularis injury, a complete tear, if the biceps is medial in position. Easily seen on MRI scans, and most radiologists will read this. Biceps being medial, and not necessarily see the subscap tear. The biceps tendon, often associated with subscapularis tear, chronic rotator cuff tears. Presentation, if they have an acute rupture proximally, is ecchymosis, pain, and then they feel better. So typically with the biceps tendon, we're now doing more and more tenodeses in patients over age 40. The slap tears, labral tears usually don't heal very well, so you debride the labrum and do a biceps tenodesis, where you park it somewhere else into bone or into soft tissue, or do a tenotomy. Repair of the other structures, such as the subscapularis and the rotator cuff, is very important, but the biceps with its pain is a significant pain generator, and we're not doing as many aggressive labral repairs in patients who have associated problems such as a subscapularis tear or a rotator cuff tear. Do a tenodesis rather than an attempted labral repair. The biceps labrum anchor is not happy if it's under too much tension. This is a orthopedic sports medicine fellow who was bench pressing, felt a rip, got nauseated. He tried to lift the amount of weight that he did 10 years previously doing bench press. So even acutely, he has this deformity in his pec. So you can have them do different palm press maneuvers, change the position of their shoulder, putting them in different Hulk Hogan positions, if you will. So, and there will be dimpling of the skin. You can see that retracted area of the pec major. This was his dominant side. He did heavy labor, orthopedic surgery, and wanted to return to lifting. So you can see here we've got his hands on his waist and we're having him come forward, but more of the position with his arm up and resisting like that is a more effective way to acutely diagnose a pectoralis major rupture. They're easier to repair earlier than later. This is a 34-year-old right-hand dominant weightlifter, pain over the AC joint. They had had an arthroscopy, labral debridement 3 years previous, and the pain was located over the AC joint. So this is weightlifter's shoulder, which is more of an AC joint problem. However, if you do a scope on these individuals, you want to look in the glenohumeral articulation as well to see if there is any labral pathology or articular surface injury, which there can be if people are using their shoulders as a weight-bearing joint. This can be done arthroscopically, but in this case, his clavicle was very bulbous, thickened, and there wasn't a lot of space. As you can see on his x-ray, there's very little space in the AC joint. This is a striker view on his involved side on the right, which is on the left-hand side of your screen, and then the non-involved is on the right-hand side of your screen. You see where there's more space on the AC joint on the left shoulder. And the osteolysis is that radiolucency in the mid portion of the distal clavicle. And notice how small, how narrow that joint is. So we did open distal clavicular resection. This can be done through the scope, but we take out that arthritic distal clavicle. Chromium does fine. And don't take out too much. Take out less than a centimeter. This can be done arthroscopically, but in this case it was easier to do it in an open way, and he did very well post-op. Few cases of unusual presentations of shoulder pain. You may not have seen it, but it has seen you. So athletes are usually healthy and don't have tumors or unusual conditions, but you got to look at the x-rays clinically, examine them, listen to their history. If they look scared, then you know there may be something more than the eye meets as far as what the real problem is. So think about things you haven't seen and critically look at the x-rays and get a feel for how scared the athlete is. This is a 31-year-old lawyer, was having shoulder pain. She had had a previous x-ray a year prior to coming to see me and was treated non-operatively initially. So she came in ready for her subacromial decompression and assessment of her rotator cuff. Repeat plain x-rays every year before you're going to operate on somebody. So if you look at the x-ray on the left, there is a lucency and a widening of the coracoid. This ended up being a coracoid cartilaginous tumor, which was graded at a grade half, chondrosarcoma of the coracoid. You can see it best on this striker view, but you can also see the radiolucency on the right on the axillary lateral view. And just pointing out the nature of the radiolucency at the base, and it just doesn't look right. So this is where you have to critically look at the x-rays, get repeat x-rays. If you have bad x-rays, get better x-rays. If you haven't an x-ray in a year, make sure you x-ray them before you operate on them, because things do change. So she underwent a coracoid resection and has done well. She would not have done well with a subacromial decompression. So she may be continuing to impinge, but remember critically looking at the x-rays, and you can see the coracoid looks more abnormal on these films, which was before her coracoid resection. She never did have a subacromial decompression. Refer her to orthopedic musculoskeletal oncologist surgeon. This is her MRI scan looked like. You can see a little better on these views. So again, there is a cartilaginous lesion occupying the entire coracoid. She might have gotten a little more symptomatic because you can see there at the tip, she might have had a little fracture through it, so had a pathologic fracture of the coracoid causing her to have increased symptoms. grade 1 chondrosarcoma of the coracoid, get pre-op x-rays, and remember to critically look at your x-rays, particularly if you're the surgeon. This is a 12-year-old male soccer athlete. He had pain in his left shoulder for 1 to 2 years before he was dragged in by his mother to see me. No injury. Had normal stability. Critically examining him, he did have a firm, slightly tender mass in his axilla. He's right-handed. So plain x-rays were normal. These are his MR images. You can see this mass that we're feeling in his axilla is pretty big. It's anterior. This is a synovial cell sarcoma that would have been missed had a good exam, listening to the young man, and an MRI scan been done. So you can see in the lower left the glenoid, you see the labrum anteriorly, and then you see this this big synovial mass. He underwent excision of this and has done quite well postoperatively. And this is the coronal view. Other structures are normal. Large synovial mass, synovial cell sarcoma that was excised. Another view showing axial view, showing the mass. Biceps is in the right place, synovial mass. So he went a limb salvage resection followed by chemotherapy. He's doing very well. He came in to see me a couple of years later for his knee pain, which he looked at me like I was going to say it was another tumor, but fortunately it was more patellofemoral stress syndrome. But fortunately he did well from his resection of his sarcoma and axilla. This is a 22-year-old whose girlfriend noticed that he had some asymmetry of his scapula. He had a history of multiple osteochondromas. Didn't really know that he had one in the scapula. X-rays show centrally in his scapula a large mass. Looks like it's been sitting there for a while, surrounding radiolucency all the way around it. Doesn't look too invasive, but it is a proximal bony lesion. You can see here circling the lesion where the lesion is. This is a true reason for scapular winging because it's a space-occupying mass. This is the outlet view on the left and the axillary lateral view on the right. You can see this that looks like bone. It's radio opaque. You can see the distance from the ribs to the scapula on the left and understand why he is having winging, because this is a space-occupying lesion, not anything neurologic to cause winging or scapular winging that we see with shoulder intrinsic shoulder problems. So since this was axial skeleton location, proximal, he underwent a resection of the mass. It was also symptomatic. The diagnosis was osteochondroma without malignant change, and he did very well postoperatively. This is his CT scan showing the mass very well as it rotates around, so you can get a better appreciation of why he wings. He's got a large mass between his scapula and his ribs. The key in making any patient happy and solving or curing their musculoskeletal problems is to make the primary diagnosis. So we as orthopedic surgeons, primary care physicians, need to listen to patients, know how to examine patients, and make the primary diagnosis. Imaging certainly helps in the shoulder. Think about doing plain films, routine views, and imaging if they don't get better. I hope this presentation has helped you be a better diagnostician and a clinician examining the joint of the shoulder. The shoulder pain algorithm that we talked about should give us a pathway for treating patients with shoulder pain. The special imaging MRI scan with or without gadolinium. I usually will do intra-articular gadolinium or order this if I'm thinking of a slap tear. Otherwise, for rotator cuff tears, we don't need intra-articular gadolinium. Scans are improving. We can see tendon problems without the gadolinium. Other special studies, you can do a abducted external rotated view of the shoulder with an MRI scan. You may see a peel back of the labrum, so that may diagnose a labrum tear. CT scans more for bony injuries or fractures, or if you're looking at somebody who has significant anterior instability, you want to assess how big the Hill-Sachs lesion is or what the size of the Bankart lesion is to figure out if you're going to need to do some bone augmentation procedures. Ultrasound is gaining in popularity more for supraspinatus tears, more for fluid around the biceps, and also for injections if there is a problem locating where exactly you want to put the injection, into what tendon or what space or joint. Ultrasound is accurate. It's a lower cost than MRI scan. It can be done in the office. And I think this will be something that more and more physicians are trained in doing ultrasound. More radiologists, as also more primary care physician and orthopedist, both as a diagnostic and a therapeutic maneuver to be able to treat the tendinopathies about the shoulder, the partial tears, and even to perhaps do some biceps tenotomies with ultrasound guidance. I refer you to this Journal of the American Academy of Orthopaedic Surgeons article regarding rotator cuff ultrasound diagnostic capabilities. This is an ultrasound showing a previous This is an ultrasound showing progression of a previously asymptomatic rotator cuff tear, 1991 on the left and 1997 on the right. So we can also follow the size of the cuff tear, which is very important when you get in on some of these massive cuff tears that are not repairable, to have counseled patients if they're having a significant progression in size of the cuff tear. Shoulder pain algorithm. Differential diagnosis categories are rotator cuff disorders, a frozen shoulder adhesive capsulitis, which we see most commonly in the perimenopausal female, glenohumeral instability, very common in the younger individual, contact as well as multi-directional instability, arthrosis in the older individual or with a massive rotator cuff tear with rotator cuff arthropathy. AC disorder, more related to the shoulder who is in a weightlifter. And fibromyalgia, rheumatologic problems. So these are our differential diagnostic categories. So in this algorithm, need specialized care, refer to a specialist, get a consult. Definition of a musculoskeletal specialist: it's a licensed physician who focuses on management of musculoskeletal conditions. It's going to be a sports medicine, fellowship trained primary care physician, orthopedist, physical medicine rehabilitation. But the bottom line is refer them, get the consult before doing a workup that may not be necessary. In conclusion, working up a shoulder pain patient, don't order a test if you can't read it. Communicate with a radiologist at your imaging center. Go over the scan. A bad scan is worse than no scan. In the state of Kentucky, we have many MRI scanners. Shoulder scans are notoriously bad if ordered by someone who is unable to examine a shoulder. So when we're faced with a patient we're now seeing in consultation with a bad MRI scan, we have to discuss whether or not we need to get yet another study or treat what their symptoms are or operate on them. So in my opinion, a bad scan is much worse than no scan, and an early consultation is the best counsel. Send them to somebody that knows what they're doing. Simon MRI report just doesn't help. This is a Chinese soccer athlete whose knee underwent an MRI scan. You can see that it says Lockman in there. I can't read anything else, but sometimes the radiologist reading is very difficult to interpret, and patients have copies of their reading, and we spend a lot of time as orthopedic surgeons describing why the radiologist read this and the fact that it may not correlate with their symptoms. So a lot of things are overread with MRI scans of the shoulder, and you need to focus on what the primary problem is. Apologies to the radiologists, many of whom are great. Conclusions: knowing anatomy, understanding biomechanics, the sport of injury, and mechanisms, we can make a diagnosis. The physical exam and the specific diagnosis are made. Physical exam makes sense if you know the anatomy and the sport, and then you can make a specific diagnosis by history, physical, and good plane radiographs. Remember in pitching, that little leaguer, 8 to 10-year-old who comes in thinking they're going to be like a pro player. Remember, little league pitchers do not become big league pitchers. And Nolan Ryan didn't start pitching until he was in high school. So imaging that young shoulder, get plain films. Most likely in an 8-year-old it's going to be a proximal humerus fracture and not a rotator cuff tear. However, we're seeing more and more younger pitchers have injuries, as we showed during this production of a slap tear and a rotator cuff tear in a high schooler. So try to put the whole picture together. Think about the neck, the back, the scapula, and the shoulder, and treat the entire patient. In that picture, he could be in a growth phase. He could have weakness of his opposite hip, so you want to examine the entire patient to make the diagnosis. There can certainly be referred pain from the neck, tumors. So remember that you may not have seen it, but it has seen you. Thank you very much for your attention. I hope you are a better examiner of the shoulder